Hello, everyone. I'm Dr. Marty Ross, and this is another Conversations with Marty Ross MD, where I'm returning after being gone for 2 weeks. So it's good to be back here again. I do enjoy doing these webinars with you, and even though I was out having fun on vacation, I actually did enjoy, I kind of miss doing these too, so it's good to be back. So as many of you know, this is a webinar, or as you all know, this is a webinar about Lyme disease. And every week we create a different webinar based on your questions. So I'm interested, as usual, seeing what you have in store for me tonight. And hopefully I can give you some help and the questions that you're posing to me as well, too. For those of you that are new, you can participate 2 ways. One, you can go ahead and listen to the responses that I give to the questions. Second way is you can write a question. And the way you do that is over on the bottom side of the right-hand side of the screen on the bottom is a chat box. And you can write your question to me in that chat box. The only thing I ask is that you don't hit the enter key until the whole question is done. The problem with hitting the enter key is it actually breaks your question into pieces and sends them to me as separate pieces, and it gets to be kind of hard to follow on my side of the computer. I am creating a recording of tonight's webinar, and I will be sending out a notice of that through your email tomorrow morning when I have it ready to go. I have to do a little bit of editing on it tonight, and then I usually like to create a brief summary of what we talked about in the webinar so that you can follow that along if you want to do that too. So look at that tomorrow morning, usually by 9:30 a.m. in the morning, I have that out to you. I'm also very glad to see a number of familiar names here tonight. I would say names and faces, but I don't get to see you, but I do see names. And so it's good to see that a lot of you are coming back and that you keep getting help here as well too. All right. So during the webinar, I will be reading your questions, but I will also post them. So those of you that are participating in the live version of the webinar will actually be able to see the questions on your screen. They don't show up in the recorded version, though. So I will read them so that everyone can follow along, whether you're listening in the live version or in the recorded version. Okay? All right. So without any further ado, I think I covered everything for background here. Let's go ahead and get started. Hello, Sai. Let's see. Welcome back, Dr. Ross. Thank you. Let's see, what is your opinion on azolecillin for Lyme? Number 2, is it true that doxycycline hyclate capsules expire a year after the day the prescription was filled and should not be used thereafter? And 3, what range qualifies as elevated liver enzymes for adult women? All right, let's take those in order. So azolecillin, excuse me, everyone. Actually, just I had a cookie stack, and anyhow, I'm feeling the effects of that. But anyhow, so azolecillin is a type of penicillin, and unfortunately, it's not currently manufactured in the United States. So many of you may be familiar with disulfiram, which has burst out of the scenes in the world of Lyme about 2-3 years ago now. And was shown in laboratory experiments to be effective against treating what is known as persister Lyme. The researcher that came up with that idea and first discovered that it can work is Dr. Rohatis out of his lab at Stanford University. Subsequently, Dr. Rohatis actually did further projects where he was looking to see what other prescription medicines that might be available and that are FDA approved that might work to also treat persister Lyme. And he discovered that azolecillin, which is this penicillin, would be effective at doing that. His experiments also showed that this would be useful against treating growing forms of Lyme as well, too. So let me just talk about terminology here. So Lyme can exist in 2 growth states. There's growing germs, and there are these persisters. Persisters you can think of as hibernating germs, all right? Probably, based on some laboratory experiments, maybe about 10% of the germs in us can go into these persisters. Maybe, I mean, it's hard to say. We haven't had human studies on it yet, but we do know they can be, that there are these things called persisters. The trouble is with persisters, we're still trying to figure out what to use to kill them, all right? So most of the standard antibiotics we use are great at the growing forms. But they're not effective against these persister forms, all right? So that has sparked a lot of research. Dr. Rohatis has his lab. Dr. Ying Zhang out of Johns Hopkins University has been running another lab that has done a lot of novel research looking at herbs and prescriptions that can treat these persisters. Okay. Now, one other terminology thing. Many of you have heard about Lyme spirochetes and Lyme cyst. Okay. And then we got this whole persister terminology. So let me try to talk about that so there's no confusion. So the Lyme germ has two appearances, what it looks like. The appearances are a spirochete that looks like a corkscrew. And that germ can change what it looks like and into a different form, which is called a cyst. Okay, so that's what it looks like. Those are the ways that it exists, okay? In addition, the spirochetes and the cyst have growing forms, and they have, growing state, a growth state, and they have a persister growth state, okay? All right, so I just want to clarify that as well too, all right? So the azolecillin on laboratory experiments looked good, like it could treat persisters and growing forms. Dr. Rahadas's experiments about disulfiram don't tell us whether they treat growing forms or not. I mean, it's hard to tell. I sometimes think the reason people fail disulfiram treatments, if they're not on other antibiotics when they take disulfiram, is because maybe the growing forms of the germ aren't being treated. And in those situations, sometimes I will add in prescription antibiotics in addition to the disulfiram as a means of treating both growing and persisters, okay? But azolecillin looks like it's going to treat, definitely, we have some lab evidence that they treat growing and persister forms, which is great, okay? Dr. Rojadas then did another study, which is a mouse experiment, where he looked to see what happens in a mouse. And it looks like in a mouse that he was able to get rid of growing and persister Lyme. So that was good, okay? Now, the trouble is no one manufactures this drug. No one's making it. Although it is FDA approved, there are no companies that currently manufacture it. There is a company that is developing this drug or is trying to develop the drug to get it on market. And as my understanding is, as part of that, they're actually conducting some human experiments to see does it actually work in humans. So I want to make a distinction there. What looks good in a mouse and looks good on a petri dish is not always good in a human, okay? So I don't know if this is going to be the wonder drug or not. We'll have to see. At this point, it's not clear if and when it will come onto market. Again, there is a company that has been doing work to try to bring it to market. I know that Dr. Rojadas was one of the following members of that company, but if we look at that company's website now, his name isn't on anywhere. He's not even one of the scientific advisors. So I'm not sure what has happened behind the scenes there, okay? So it could be promising. We'll have to see, all right? Okay, number two, you asked about doxycycline and expiration. So for whatever reason, I don't know I don't have a solid understanding of why, but manufacturers of antibiotics do have to put an expiration date of 1 year after manufacture, all right? Does that mean these drugs are no good? All of them at a year, everything goes boom, it doesn't work anymore? No, but they put that on there, and so it's probably a lot of these antibiotics that supposedly expire one year after they've been manufactured likely are still effective. In fact, the U.S. military a number of years ago looked at a number of their products on their shelves that had expiration dates of a year or more and tested them to see are the chemicals still active in these expired formulations, and they were. So the problem is no one's done studies on each of these drugs to tell us how long do they really remain active after a year. But I'm inclined usually within a year or 2 years of expiration to still use antibiotics, even if they are in expired bottles, okay? Because there's no reason to think that a lot of these chemicals are just going to deteriorate on their own, okay? So a year is a magical number. It's not a research number, it's magic. And so those drugs probably still work even after that magical expiration date, okay? All right, number three, let's see. Okay, what qualifies as elevated liver enzymes? So when you look at, so the liver enzymes, the ones that I like to look at, that I follow to see if there is liver inflammation, is something called ALT or AST, which are also known as SGOT and SGPT, okay? They're the same stuff. What you want to do, every lab reports a different level on these, what they consider normal. But all labs, when you get a report back, will have a range of normal. So for instance, an AST, a lab might report a normal range of 10 to 40 for an AST, okay? They're usually somewhere in that ballpark, and it will say the range. It can be from 10 to 40, okay? So that 40 is the upper end of normal. And what I like to do in my treatments, I acknowledge that these antibiotics that we put people on may lead to some small degree of liver inflammation. I am okay with liver inflammation showing up with an AST or an ALT that goes up to 2 times the upper end of normal. So what I mean by that, if an AST, the lab says normal range is 10 to 40, 2 times the upper end of normal would be 80, okay? So generally I'm okay with that. The reason you don't want to have prolonged high levels of inflammation above that 2 times the upper end of normal is prolonged inflammation of the liver could lead to scarring of the liver. And chronic scarring of the liver is a condition called cirrhosis of the liver. And eventually the scar tissue gets to be so big that it scars out the well-functioning cells of the liver, okay? But that's not going to happen when you have these mild degrees of inflammation. Up to 2 times the upper end of normal is what I accept, okay? Now, if I've got somebody that's nearing that limit and I still want to keep leaving them on a drug, I'll do things to support the liver. And one of the best things I have found to support the liver and to lower that inflammation, even when you're on a drug inflaming the liver, like a rifampin or a rifabutin that can do that, or a tinidazole or a metronidazole, all those that can inflame the liver. What I like to do if I'm starting to see those numbers creep up is I'll put a person on glutathione. So glutathione, many of you know, is a very strong antioxidant that is made in every one of our cells. Its purpose is to fix injury. Okay, the cells make it to repair themselves. And it's made in very high concentrations within the liver, where it's also used as part of the detox that the liver does. It's also made in very high concentration in brain cells to help keep the nerves repaired and functioning well as well too. Okay, so if I've got somebody whose numbers are creeping up, I'm going to go ahead and get them on glutathione. I prefer using liposomal glutathione, meaning it's microscopically wrapped in fat. The reason I like using microscopically wrapped in fat glutathione is to get it absorbed, okay? And the product that I like to do that is made by Research Nutritionals. It's called Trifortify, Trifortify Orange, Trifortify Watermelon. Usually have people take about a teaspoonful of that 1 time a day if I'm using it to help their liver work better. Research Nutritionals has got some very good studies showing marked increased levels of glutathione inside red blood cells for people that actually take their product, which suggests that you're going to have elevated levels in all cells throughout the body as well too. Okay, so it's a researched product that actually shows that what they say it does it. Okay, all right, very good. Good luck to you, Sai. Thank you for that question. Oh, one more thing. I would not make a distinction between adult women and adult men in terms of what the upper end of normal would be here. Okay? All right. Hello, Dave. Hi, Dr. Ross. I hope you had a great time riding your motorcycle and visiting your dad. I did. Thank you. My father actually just turned 90 years old yesterday, so I had ventured out to see him in Colorado Springs on my motorcycle to help celebrate that milestone in his life and try to combine it with my typical end of summer trip that got delayed about a month this year. So I will share one story with you about my trip. I found myself as I left Colorado on US 50 in south central, cutting across, going towards Utah. And US 50 is a beautiful road. I mean, right now, this time of year, the aspen are all changing color, and it follows the headwaters of the Arkansas River, winds through the mountain and everything. But suddenly I discovered I was at 10,000 feet going over something called Monarch Pass in the snow. It was snowing on me on my motorcycle, and it was 35 degrees. And I was in a cloud. So it was a very challenging but fun trip as well, too. But that happens to be one of my more memorable moments. But I was able to get through, as you could tell, because I'm back here. But thank you. I did enjoy the trip. Let's see. My question is the following. If you are still living in a home that is contaminated with mold and aren't able to move out of the residence, do binders help at all? Or do they only work and remove the mold from your body if you aren't exposed to the environment while taking the binders? We can't find a new place to live at the present time. Thanks. Okay. So In terms of, let me just describe mold toxicity first, and I will answer your question. So according to the work of Dr. Richie Shoemaker, who's the person that first discovered that there are people that can have mold toxicity, about 25% of all people have a genetic programming situation where they are programmed in a way that if they breathe in mold toxins that get absorbed into their bloodstream and through the lungs, that they are not able to get rid of them. Okay, what happens in 75% of people is due to correct genetic programming. When we breathe in a mold toxin into the lung, it gets absorbed into the bloodstream. Some of our white blood cells will come in and say, aha, a mold toxin, and tag them. Okay, and then other white blood cells will come in and break down those tag toxins. That's what's supposed to happen. But in 25% of people, the white blood cells do not tag those mold toxins, so they don't get broken down. The next line of defense is the liver. And these mold toxins go to the liver. The liver is in charge of getting rid of fat-soluble toxins. Mold toxins are fat-soluble. And the way that they get rid of fat-soluble toxins is they transform them into water-soluble toxins. But guess what? The liver can't do that either. So the liver is not able to transform these mold toxins into water-soluble toxins. So they then go into the gallbladder and out into the intestines. Now, if they were water soluble, they would mix in our poop and we'd poop them out. But that doesn't happen because they're fat soluble. So out in the intestines, because they're fat soluble, they get reabsorbed back into the bloodstream again. So you just get this endless loop going on. Okay. All right. Now, what determines how much stays in you in this situation is whether you have more coming in and whether you are able to remove some. Okay. And the total level of toxins that you have in you is determined by how fast they're coming in and at what quantity they're coming in versus the quantity that you can remove at the same time. Okay. So it is possible when somebody has mold toxicity illness and they are in an environment that cannot be totally cleaned up to use enough binders that is removing those toxins at a faster rate than they're coming in. It's possible, okay? So typically, if I've got somebody that is living in a place that they cannot get totally clean, I'm going to tend to want to use my mold binders, work up to that, if I can, to a person taking them 3 times a day instead of 2 times a day. I'm going to try to be more aggressive at the amount of binders that I might use, okay? And so many of you know from these webinars, binders that you can use a prescription called cholestyramine. You can use combination herbal products like a product called GI Detox by Biobotanical Research that has in it some bentonite clay, charcoal, silica, humic acid, folic acid. Research Nutritionals has a similar product now that they came out with a few months ago called Mycopole, has similar ingredients in it to what the Biobotanical Research product does. But those are the kinds of things that you can wind up using to get these out. So I would err on the side of taking at least 3 times a day if you can tolerate that, to keep up at what's coming at you. Okay. All right. And maybe get ahead of the game too. Let's see. I just want to make sure I answered your question all the way here. Yeah, I think I answered that. Yeah, they can help. Even if you have toxins coming at you, you can still keep removing them and maybe get ahead of the game if you take enough of those binders. Okay. All right. Good luck to you, Dave. Hello, Natalie. Let's see. What is the dosing of clotrimazole you use for Bartonella? In your clinical experience, is there any systemic absorption when it's compounded, or should it be liposomal? Have you seen it also help with yeast? Thanks for your help. So that's an interesting question. So what Natalie's talking about, everyone, is about a year and a half, maybe 2 years ago now. It's coming up on 2 years ago. Dr. Ying Zhang and his lab at Johns Hopkins University published a study looking at options that we could use to treat for persister Bartonella. And Dr. Ying Zhang's lab was the first lab to discover that, guess what? Bartonella also has persisters, just like Lyme does, okay? And in his initial publication, he was looking at what could you use to treat it. And he looked at a number of prescriptions, and he basically did a test looking at prescriptions where he would choose a single member of a family. Okay, so for instance, for the tetracyclines, which includes tetracycline, minocycline, doxycycline, in his study, he looked at doxycycline as a representative of the class. For the macrolides, which is azithromycin, and Biaxin, which is also called clotrimazole, he used azithromycin. And for the rifamycins, he used rifampin, not rifabune, okay? But he was just trying to see, does the class work in some ways, okay? And so for the class of azoles, he chose clotrimazole, all right? So what else is in the class of azoles? Well, metronidazole, which is flagyl, is an azole. Tinidazole, which we use, we also use sometimes to treat for cyst Lyme, is an azole. Fluconazole, which is diflucan, is an azole. Voriconazole, which we use to treat some yeast infections sometimes and some fungus infections sometimes. We have to use it carefully. It's a very strong medicine, but that's an azole. And itraconazole is an azole, that's Sporanax, okay? So clotrimazole is only manufactured for topical administration and creams, all right, to treat fungus, ringworm, yeast infections on your skin. There are no manufacturers that make it in an oral form. There are some compounding pharmacies that will put it into a capsule for you. And to help increase the chances of absorption, they'll do a liposomal variety, okay? The trouble is, though, we don't know how well they really are absorbed, even liposomally. Because of that, what I have decided to do is rather than use clotrimazole, I will sometimes use one of the other azoles instead. So I usually will use like a fluconazole or an itraconazole. Those are the ones we use for yeast. I use those. I'll add them in and see if they make a difference on my Bartonella treatments, and sometimes they do, okay? And so basically I'm using Ying Zhang's experiments as a guide to families of antibiotics that may work, or antimicrobials that may work, all right? I have not specifically used the clotrimazole because I don't know about absorption on it. I really don't. I do have information that tells me itraconazole, fluconazole, voriconazole, metronidazole, tinidazole, all those azoles, they do get absorbed into your blood. And so that's what I tend to use as one of those. Okay? All right. Natalie, thanks for your question. Hello, Jim. Let's see. I think you mentioned that you recently started using Cryptolepis for Lyme and Bartonella as well as Babesia. How have results been so far with Crypto for Lyme and Bart? You've also said you suggest either Cryptolepis or Japanese Knotweed for those who can't tolerate oregano oil or the oregano, cinnamon, clove combo as part of Bart persistent treatment. Is Cryptolepis or Knotweed more effective for this purpose? Those are good questions. So, as I've said earlier tonight, this world of persister Lyme and what to do for, well, persisters in general, persister Lyme and persister Bartonella has been getting a lot of attention. And I think about 6 months ago now, there was some, in cooperation with Dr. Yang Zhang, there were some other physicians, a couple of them based out of California, that conducted an experiment looking to see what herbal antimicrobials might also do help with persister Lyme, and a persister Bartonella. And they discovered, kind of to my surprise, and I think surprised a lot of people, that Cryptolepis does quite an effective kill in the lab for Bartonella and Lyme, both growing and persister forms. That was the key part, both growing and persister forms, okay? They also showed that Japanese Knotweed does a nice job, and they were able to show that Chinese skullcap does a nice job for all of those, okay? In my practice, I have started working again with the Cryptolepis and the Knotweed. My experience is I'm finding Cryptolepis to be a bit stronger. I'm finding some better results using the Cryptolepis to help move treatments along, okay? Now, keep in mind, Cryptolepis, most of us were only using it to treat Babesia a few months ago. We really weren't using it as something to treat Lyme and Bartonella. So this is pretty new stuff. Most of us that are starting to use it for those organisms, it's only been within the last maybe 3 or 4 months that we've been doing it. So I can't share with you research because no one's done comparison research here, but my clinical experience is that yes, both of them can move a treatment along for both Lyme and Bartonella, for growing and persister Lyme and Bartonella. I'm seeing stronger results out of the Cryptolepis. Okay, I can't quite give you a degree difference yet at this point, but my sense is the crypto that seems to be a bit stronger on that. Okay, all right. Good luck to you, Jim. So what Jim may be referring to, everyone, I'm just going to show you an article because I wrote about this in, I think, my most recent article, which since I've been traveling so much lately, or not working and traveling, I should say, makes it sound like I'm gone all the time. I'm not. I'm actually here a lot. But anyhow, as of lately, because I was vacationing and I haven't gotten to putting an article out back in a bit of time. But one of my more recent articles was about this. So let me just do a quick screen share here. All right, so take a look. If you're ever wanting to know what is the most recent thing I wrote, take a look here on my big drop-down menu for my online Lyme guide. Take a look at this latest tab over here on the left. And so, I guess it wasn't the latest. So the latest was what I said about, I think that COVID vaccine is a good idea. You can read more about that there. And you anti-vaxxers, you should read it first before you start yelling at me for it, but take a look at it. And then, but here's my article. I guess it was 3 articles ago. This is the one about how to treat persister Lyme and Bartonella, where I describe the herbal experiments that I was just talking about. I lay out a number of other ways to do it too. Okay. All right. All right. Good luck to you, Jim. Hello, Flavia. Thank you for saying hi. I appreciate that. Hello, Lynn. Hi, Dr. Ross. I'm trying to look into some other conditions besides Lyme that might be contributed to my symptoms. Can you go over the way to properly test for thyroid function and how to screen for autoimmune conditions more generally? My main symptoms are muscle pain and dysfunction, fatigue, weight loss, and rapid changes in skin. Can you also recommend how to test for adrenal problems? Okay, so let's start first. If I have somebody, not you, but if I have somebody in my practice that comes in that has a lot of joint inflammation, fatigue, and muscle achiness, there's some basic studies that I want to look to see that sometime before they saw me or as a part of our first visit, that I'm going to want to make sure that somewhere these have been done, okay? One, especially here in the Pacific Northwest, is vitamin D3 levels, also known as vitamin D25 hydroxy. Here, if you're above the 45th parallel, which would be middle of Oregon going north, the 45th parallel, we don't get intense enough sunshine even when it's out. Now, it's out all the time in the summer here, but 9 months out of the year, we're cloud covered here. But even in the summer, we don't have intense enough sun to create active vitamin D in the skin. So vitamin D has to be activated in your skin. And if not, you have low active vitamin D levels, okay? Low active vitamin D is critical for hormonal function, neurologic function, and can give you fatigue, might even give you muscle achiness as well too. Okay, so I would get a vitamin D level. All right. Number 2, I would, in terms of other things to look at that could indicate inflammation, I would want to get a rheumatoid factor test. I would want to get an anti-nuclear antibody, also known as an ANA, with something called reflex. ANA with reflex, and means if the ANA comes back positive, the lab automatically does a bunch of other immune tests to figure out what is the cause of the ANA going positive. So ANA being positive, sometimes it's called the lupus test, but there's other things besides lupus that cause ANA to be positive, okay? And you can, there's other immune panels you can do if this is positive to figure out, is it lupus or is it scleroderma or is it something else that is causing the ANA to be positive, okay? I might get a C-reactive protein. I might get a SED rate, okay? And then always, I want to make sure what is happening with kidney and liver function. So a CMP, I would want to get a blood count, a CBC. If I've got somebody that also, when they come in to see me, has a lot of neurologic problems to go in the beginning, I'll get a vitamin B12 level. Those would be some basic things I might do at the beginning. Okay. All right. Now, in terms of thyroid, I will look at that too. And my basic thyroid panel for somebody, as you've just described, would be to get something called thyroid stimulating hormone, which is TSH. I would also want to measure the actual thyroid levels that are in the blood. And that would be to measure a free T4 and something called a free T3. And I would also want to measure one other thing, which is called a reverse T3, okay? If somebody also has a lot of inflammation, I might get thyroid antibodies called TPO antibodies to see if they have an autoimmune condition that not only is giving them achy body pain, but is attacking their thyroid. All right, so let me talk about those thyroid tests. So TSH is a chemical made by an area of the brain called the hypothalamus pituitary. The brain makes TSH to tell the thyroid, which sits here, to make its stuff, okay? And what the thyroid makes is T4 and T3 thyroid hormone. T4 has 4 iodine particles and T3 has 3 iodine particles, okay? All right, now, so that's one of the differences between T4 and T3 is the number of iodine particles they have on them. The other big difference is two more differences. 90% of what the thyroid gland makes is T4 and 10% is a T3, roughly, okay? All right, so that's the second difference. Third difference is what is active in your tissues that makes you run and gives you good energy is T3, all right? So that T4 has got to be converted in your tissues and in your cells into T3. Now, one of the things that can happen when you have a fatiguing illness or a chronic health condition is that the body, to heal, wants to put itself into hibernation, all right? And so one of the ways to go into hibernation is to slow down your metabolism. So the body, and we're not quite sure exactly what the signal is on this yet, but the body may want to go ahead and make it so you're not making as much T3. Right? So instead of allowing all that T4 to become T3, the body may say, we're going to go into hibernation here. We're not going to let you have all that energy. All right. So what happens with T4's got a choice. To make you run really well, it can become T3. Or it can have a different choice. It can slow you down by becoming reverse T3. Okay. All right. So you want to look and see what's going on with that reverse T3 too. Okay. All right. So those are some basic tests I would do if the situation like you just described. Okay. Now, what about adrenal testing? So your adrenals are an endocrine organ that sits on top of the kidneys. And they make a variety of chemicals, including cortisol, which is considered to be your stress hormone. And they also make DHEA, which is a chemical that can be converted into testosterone. All right. And then they make a group of chemicals called mineralocorticoids that are used to tell the kidneys to hold sodium and other minerals, not pee them out, basically. All right. There are doctors out there that will measure thyroid function by doing saliva tests, where they'll have you spit into a tube a few times or 4 times throughout the day to try to see what your adrenal levels are. There are competing feelings about that. If you look at the reliability of the saliva test, it varies. You can take that same sample and send it to multiple labs, and they'll all have different results. So it's not, I tend to think there's enough reliability issues with saliva adrenal testing that I don't do it. The only thing I do is to get an early morning cortisol test. And by that, I mean a test before 8:30 in the morning. I usually try to have my patients be fasting, and I'll wind up doing an AM cortisol, and I'll wind up doing a DHEA sulfate. That's how I do it. Now, I got to admit, there's other practitioners out there that will do the saliva testing. I just have questions about intra-lab reliability and therefore reliability of that kind of testing technique. Okay? All right. Thanks for that question, Lynn. Good luck to you. Hello, Robert. Let's see. Thank you for sharing your expertise. You're welcome. Let's see. I started 6 weeks ago, glutathione, ATP 360, curcumin protocol, and doing well. After a week, I started Lyme persister protocol with cinnamon, clove, oregano, cryptolepis, and resveratrol. After about 2 weeks, I had significant inflammatory cytokine response, maybe Herxheimer. I stopped the 2 new supplements, resveratrol I've been taking several years, got better, then tried each individually and found that 2 doses of the oil, of the cinnamon, clove, oregano oil, would bring on a Herx. Cryptolepis is tolerated better. Can I dissolve a capsule of the oil in water to 1/2 dose and build up tolerance? Possibly my system is a little overwhelmed with the concentrated formula and not metabolizing quickly enough. Thanks. Yeah, so it's really interesting. I have found people that, so everyone, liposomal or Dr. Ying Zhang's lab, you've heard me mention him a number of times. I'm seeing our theme tonight. Our theme tonight is what to do for persisters and all the herbal options out there. So we tend to do that every now and then. And I know none of you have been talking about your questions, but I'm getting a number of persister questions tonight, which is good. Anyhow, the Dr. Ying Zhang, in his studies of about 2 years ago, probably about 2 years ago now, it's all starting to become a blur, but around 2 years ago, he was able to show that the herbs cinnamon, clove, and oregano all are effective at treating persisters, Lyme, and Bartonella, and also probably can break down biofilm as well too. It's very interesting. I am finding them in some people to be very, very strong to cause significant Herxheimer reactions. So a standard dose I like to use is a product that's made by a company called Doctor Inspired Formulation. That's liposomal cinnamon, clove, oregano oil essentials. Okay. And the dose I usually like to get people to, and I even start people at, is 1 pill twice a day. There is an occasional person that just gets clobbered with that. And so then I'll try to go down to 1 a day. If they still stay clobbered, what I have been doing is to try to have them hold off on using that product, but instead get oregano oil drops that are not liposomal. And the company that makes the product that I've been using is Gaia. Gaia Herbs makes a oregano drop. And I'll have them start taking about 1 drop twice a day, realizing that because it's not liposomal, it's not as strongly absorbed, but some of it is getting absorbed. And I have found that the easiest way to get a lower dose on the oregano. I will try to build them up to taking about 10 drops twice a day of the oregano. And once they are tolerating that, if they're doing okay, then shift over to the liposomal cinnamon, clove, oregano oil capsules. All right. And when I do that, then I'll start at 1 a day. And as tolerated, then I might go up to 1 twice a day. Okay. So I'm going to suggest to you, rather than diluting it in something else, what you might do is just get a different product. Set that one aside. Get the Gaia Herbs oregano drops and find a level that's more tolerable. If you can get up to 10 drops twice a day, then at that time, go ahead and switch over to the liposomal product. Okay. All right. All right. Good luck to you, Robert. Thank you for that question. Hello, Kate. Let's see. Hi, Dr. Ross. I had acute Lyme and I've been treated for more than a year now, but I've had chronic eustachian tube issues since. My IgE is high and I'm currently doing low-dose naltrexone and allergy shots. Why would this happen during or after Lyme? By the way, I did 3 months of antibiotics and 7 to 8 months of herbals. I did have candida overgrowth, but not anymore. I also know I tested positive for a candida allergy as well. All right, so IgE, everyone, is a family of antibodies that will be elevated when you have allergies. Okay, and in a situation where somebody has developed allergies or high levels of IgE while they're on antibiotics, herbal or prescription antibiotics, I always question if you could have too many intestinal yeast. So, and you've said you don't, but just hear me out for a minute. So intestinal yeast, everyone, we all have yeast that live in our intestines. And generally they're kept at bay, under control, in balance by the good bacteria that are there. But if we knock down those good bacteria with prescription or herbal antibiotics, then sometimes those yeast can grow too much. Now, 70% of your body's immune cells line the intestinal tract, okay? And it's very easy for them to develop an allergic type reaction. Of a group of cells called mast cells will develop an allergic type reaction to all this extra candida growing in the intestines. So even though you've said you don't have candida, and I'm going to go into how I would want to make sure you don't, but if you do have candida overgrowth still, even though you think you don't, that could be triggering IgE, okay? Another thing that sometimes rarely can give IgE is if you happen to have parasite infections in the intestines too, that somehow got unmasked by knocking down good bacteria that were also keeping those under control, okay? All right, now, how do you determine if you really don't have candida in your intestines? All right, let's just talk about that. All right, so the reliability of a poop test to see if you have candida is not good. All right, because you can do stool testing, and if you get a test back that says you got candida, well, guess what? We all have candida. All right, and if it's not there, I have found that it's not reliable because often people still have a lot of symptoms of yeast and their testing comes back negative on a poop test, but I will treat for yeast and they get better. Okay, so the reliability of a stool test about whether you have yeast is not reliable. Okay, I just want to let you know that. Okay. I find what is reliable symptoms. So if you've got a lot of gassiness, bloating, sugar cravings, pimples, acne, vaginal itching, vaginal discharge, allergic type conditions, think yeast, and still consider treating. Okay, that's what I do in my practice. Okay. If you want to get some laboratory evidence if there's yeast, I know some practitioners will measure to see if you have yeast antibodies, either IgM or IgG. Again, those are not reliable because if they come back positive, guess what? We all have yeast that live in our intestines. Having antibodies does not tell you there's too many, okay? But again, you can have yeast, and I have found that IgMs and IgGs are not positive. I don't consider that a reliable method. More recently, over the last 1.5 to 2 years, I've started looking at doing an organic acid profile. And I use Great Plains Lab for that. They do something called a MOAT test, M-O-A-T, which stands for metabolic organic acid. I don't even know what the T stands for here all of a sudden. But anyway, their MOAT test, okay? It's an organic acid test. Oh, that's it. Metabolic organic acid test. That's the T part of the test. Anyhow, they look at organic acids that are released by bacteria, fungus, and candida yeast. And on that profile, the one that has the most accuracy at indicating if you have too many yeast in your intestines is something called arabinose, all right? And so I would consider, in a situation where you're describing you've got a lot of eustachian tube dysfunction, that can be due to intestinal yeast causing activation of your mast cells that line your intestines, releasing histamines. Those histamines get into your bloodstream, go up through your body, often can give you a lot of sinus congestion here and congestion of your eustachian tubes as well too, okay? That's what I would look for. And I would look for it even though you think you're negative, and maybe you've already done all this, okay? But if you have not done the arabinose test, I would go back and relook at that again. So that can be done through a Great Plains Lab, okay? If you have done that and that's negative, then you may want to talk to your providers about starting to analyze you to see if you might have intestinal parasites. Intestinal parasites can be hard to see. If you're going to do stool testing for it, I would look at either using the Great Plains Lab, their GI stool profile, or Genova Diagnostics as a means of doing microscopic exam of your stools to see if you might have parasites there as well too. Okay? All right. Good luck to you, Kate. Kate, again, I am not your physician. I'm giving you things that you might want to talk with your provider about. Okay? All right. Good luck. Hello, Steve. What is new in the Lyme business? Well, I mean, we've been talking about some of it tonight. Persisters. It's all about persisters these days. The other thing, I know that a number of my colleagues are using, and I'm calling it the latest bright, shiny object that everyone's running to. I don't know how many of you have been around here for a long time in the world Lyme. A lot of you I know have been, but as many of you know, every year we come up with the treatment that everyone flocks to. I think a year ago it may have been SOT. This year it tends to be something called peptide therapy. A few years back it was disulfiram. I mean, every year we come up with the shiny object of the season. Most of them don't stand the test of time. They just don't, okay? This year, the new thing in Lyme is peptide therapy to heal damage. I still would say that the jury is out. And in fact, I'm going to be going to the ILADS meeting next week down in Orlando, and we'll be participating in a day-long workshop on peptides, trying to get a bit more information for myself. But so far I've been kind of skeptical at what I've seen on it, but I know that some of my colleagues are using it, and so some of you may be on those as well too. And for me, I'm still thinking the jury's out. Okay, all right. Good luck to you, Steve. Hello, Liz. Let's see. Hi, Dr. Ross. Is the binder chlorella good for for stacky? I thought you said starchy, but for stacky mold, Stachybotrys, everyone, which is black mold. Also, what are your thoughts on TOA and cat's claw? Does cat's claw lower progesterone and estrogen? Thanks for all you do. Okay. So cat's claw, I do see that periodically people get an estrogenetic effect from it, meaning it has, my experience is that it doesn't necessarily trigger more estrogen, but it has an estrogen side effect. It acts like an estrogen in some people. I don't believe it alters progesterone levels, but my experience is that in some people it has an estrogen effect. And how that will show up is people on cat's claw sometimes can get a lot of pimples or sores that look like pimples. Okay. All right. So I have seen that happen before. I don't know that it actually lowers progesterone. That hasn't been my experience. Okay. All right. A TOA is a group of alkaloid chemicals that are in cat's claw. Nutramedics basically manufactures something called a TOA-free cat's claw, and they think that's better. And then you have Stephen Buhner and Buhner Herbs that basically thinks that having TOA in the cat's claw makes it more effective. Okay, I tend to be more of that camp. I do think the TOA free cat's claw is a marketing gimmick by Nutramedics to try to say that there's something different and wonderful. But one of the arguments against having TOAs is there's a concern that alkaloids could be harmful to the liver. At the doses we use these, I don't see that happening, actually. And I would probably lean more towards Buhner's interpretation, which is cat's claw that it has alkaloids in it, TOAs in it, would actually be more effective than like a Cemento TOA-free version that Nutramedics is doing gimmick marketing of. Okay, that's how I look at it. Now, they may not be happy for me saying that, but that's my opinion on it. Okay, all right. Anyhow, let's see. Yeah. Oh, chlorella. I tend not to use a lot of chlorella because I just don't see big results with it. So I don't know that one off the top of my head. I can't tell you that. I apologize for that. I would have to look it up. I just don't know it off the top of my head. Okay. All right. Good luck to you, Liz. Hello, Kathleen. Hi, Dr. Ross. Thank you for answering our question. You're welcome. Do you think that genetic testing is helpful when trying to come up with a treatment plan for tick-borne infections and mold? That is the route I'm going because nothing that I've tried has been helpful. I've tried antibiotics and herbals, but not helpful in alleviating symptoms as yet. The geneticist found that I have the MTHFR variant along with FE1 variant of this, so I may have difficulty eliminating iron. I'm also a carrier of celiac and was advised to eliminate gluten. Could my detox pathways be blocked to the point that no treatment will be effective until this is addressed? So I'm going to give you my opinion on the genetic testing that everyone is doing or has been doing, and my feelings on this and my working with it has evolved over time as more information has come to light. Okay, so probably about maybe 5, 6 years, maybe 7 or 8 years ago, a lot of us were trying to do MTHFR genetic profile testing on all of our patients. And so everyone, MTHFR stands for methytetrahydrofolate reductase. It's an enzyme, okay? And it's responsible for governing the conversion of diet folate into an activated folate called 5-methytetrahydrofolate or 5-MTHF, okay? That conversion of diet folate to activated folate is the first step in the methylation detox pathways in the liver, all right? You need that step to take place. If you don't get that step, then ultimately downstream, you don't have enough production of glutathione and your detoxing doesn't take place well, okay? Before you even get to glutathione, there's a bunch of other minor detox reactions that happen too, but the big one is manufacturing glutathione that then goes on to help with a lot of other detoxing. So a lot of us used to rush off and do these MTHR tests, and if it came back positive, we were giving people B12 and the activated folate, 5-methytetrahydrofolate, at high doses, trying to correct this problem that the genetic profile said a person has, okay? All right. I've changed my thinking quite a bit on this, all right? And here's why. So we now know over the last years that there's been a huge amount of studies going on looking at our gut microbiome, all right? Now, what does gut microbiome have to do with your genetic profile test? Just hear me out on this, all right? So your gut, if we look at the genetic material in our body, about 90% of the genetic material in our body is from the germs that live in our gut. 90%, all right? We are letting a lot of stuff just live down there, okay? And, you know, we're not letting them live there for no reason at all, right? We're just not feeding them just so because we can carry them around for no reason at all. We're getting something from those germs. We're getting something from the viruses, the healthy parasites, the healthy yeast, the healthy bacteria, all that stuff that lives in our gut. We let them there because we are selfish. We're getting something from it, okay? All right, so what do we get? Well, all those germs help do some digestion. They actually do microscopic breakdown of food. They remove toxins, okay? They can detox. They can pull things out, all right? They make chemical messengers that get absorbed and tell our brain to work correctly. They make chemicals that help our immune systems work better, all right? And the other thing they probably do is they make up for our genetic problems that result in a low 5-MTHF. So they may manufacture 5-MTH for us because we want them to do that, okay? So subsequently, what I've started doing with my MTHR testing, for instance, is if I've got somebody that comes to me and they have an MTHFR defect genetically, I want to know not only do you have a genetic defect, but do you manifest the problem? All right. So you may have a bad blueprint, but maybe the building still comes together well anyhow. Okay. Because these bacteria are great workers and they can still help make sure you build the right chemicals that you need. Okay. All right. So the way to see if the MTHFR problem manifests is measure a chemical called homocysteine. Even if this is abnormal, and you have normal homocysteine levels, it means you still have adequate 5-MTHF in your system, probably produced by all these good germs in your gut. Okay. All right. So fortunately for MTHFR, we got another chemical test we can do to say, do you manifest the problem? With a lot of these other mutations that you're describing, we don't have good tests to see. Okay. And so I'm not really doing the genetic testing right now because I'm thinking we don't have an adequate way of knowing really which deficiencies you have genetically actually manifest a problem, nor for a lot of them do we actually have a way of checking blood testing to see if you actually manifest the problem. Okay, we just don't have it. Okay. I generally have not found much benefit by chasing all of the different defects. I generally, in my practice, also have just not found great improvements by chasing all of those defects too. So, unfortunately, I don't know that this is the way for you to go. I'm not going to tell you not to because I don't know all the other parts about your health and exactly what you've tried. But I have seen people with a story similar to what you've described here. And if I sit and listen to the story, often I can find reasons they didn't get better that have nothing to do with what happened with their detox pathways. Okay. All right. The one big thing, now maybe you've looked at this already. You've already looked at mold. Anyhow, I would need to ask you a lot more questions to figure out is there another reason you're not getting better. Okay. All right. Good luck to you, Kathleen. Oops. Hello, Sandra. Hold on here just a minute, everyone. Let's see. I'm treating Babesia and Lyme with azithromycin, atovaquone, and a biofilm buster. I'm ochre toxin positive. Can I treat the ochre toxin at the same time? If so, what should I take? All right. So first of all, you should ask your doctor, see what they think about this too, okay? Because I can't be your doctor. I can just talk in generalities here, all right? All right, but I do, in my practice, I will treat for mold toxicity at the same time that I treat for Lyme, Bartonella, Babesia. So the answer is, yeah, you can mix things together. In terms of what you can take for ochre toxin, I'm just having a blank here. Hold on, I have to look this one up real quick. I apologize. We'll look it up together. I'll show you where you can find the answer to that. I'm having one of those nearly 60-year-old moments here. So just a minute here. All right, everyone. Take a look at I'm on my online Lyme guide. Take a look in the detoxification section here. And look at my article called Mold Toxin Illness. Down here, I talk about different binders, okay? So specific binders for ochre toxins, they're best bound by either cholestyramine and or activated charcoal. So either charcoal or cholestyramine would probably be your best bet for ochre toxins, okay? All right. Good luck to you, Sandra. Hello, Alex. Let's see. Good evening, Dr. Ross. I've been suffering for 14 months from what I thought was bad acid reflux. This reflux started after a 7-day course of naproxen. I've been battling Lyme disease for 3 years. Treating most of the time the 3 Bs, and I think by that you mean Bartonella, Babesia, and Borrelia, which is Lyme, with antibiotics. Despite trying various PPI, black licorice, aloes, and famotidine, nothing could rid me of the major ongoing reflux. Things became worse 2 months ago, where I sometimes have difficulty swallowing. I always feel like something is stuck in my throat too. Could Lyme be causing all this? If so, is there anything I can do to stop my stomach esophagus issues? As an additional information, note that the reflex burning in throat occurs between 3 and 5 hours after main meals. Thank you. Alex, I'm going to suggest that you see if you can locate a functional medicine doctor who can help you look at whether you actually are making too little acid in your stomach, okay? There's actually a test you can do where you swallow a string and it measures acid levels. Not all heartburn is actually due to high acid. Sometimes it can be due to not having enough acid production, in which case taking acid can sometimes fix the problem, all right? But you're going to need to find a functional medicine person that understands functional medicine, gastroenterology, basically, all right? If you're wondering how to do that, take a look at, there's a group that I belong to called the Institute for Functional Medicine, IFM, and they have at their website, they would have a doctor locator finder where you can find physicians that have been certified or trained by them. I've been trained. I haven't certified with them, but I've trained with them. So they would have people that might be able to help you look at that as well. Okay. All right. The other thing, so that's to consider if that's what might be happening. I wouldn't think of Lyme giving a gastritis or acid problem like this. I haven't seen that. I would be looking more at, are you making enough acid? Okay. Also, if this has been going on for some time, you may also want to make sure that you've talked to a gastroenterologist, because given the degree of discomfort you're having, at some point somebody needs to look inside there and with doing a light scope to look down to make sure that you don't have, and I'm not trying to scare you with this, but when you have ongoing pain that's gone on as long as it has with you, somebody needs to look in there to make sure that the worst case scenario, cancer, is not occurring too, okay? So we have to be careful in the world of Lyme to not attribute every problem that happens with somebody who has Lyme to Lyme or to even the antibiotics or other things that we take. Sometimes people get other real world problems as well too, okay? So with the degree of discomfort you're having, unless somebody has already done this with you, I would also, if you were my patient, I would be entertaining the idea of, do I need to get a gastroenterologist to scope you to make sure we don't have something bad going on in there too, okay? All right. Good luck to you, Alex. Hello, Natalie. Let's see. What is the dosing? Oh, we already talked about that. Hello, Bill. Hi, Marty. Did you ever find... Oh, Bill, I'm sorry. I forgot to get back to you on this one. I have not. So there is a t-test, everyone, a microscopic test that has been developed for Bartonella by Dr. Mosignani. And he has been doing this. Bill, I haven't been able to locate how to do it. Now, I'm planning on talking with Dr. Mosignani next week when I run into him at ILAD. So I should have an answer for you after that. I know I'm just not familiar with the particulars on it, and I cannot locate it anywhere as well, too. But I plan on talking with him directly when I see him this next week. Okay? All right. Take care, Bill. Thank you. Hello, Patsy. Hi, Dr. Ross. I hope you had a nice holiday. Have you heard of hydromycin A for Lyme disease? Thanks. Patsy, no, I have not heard of that. And thank you I did have a good holiday. Thank you for that. But I'll have to look this one up. I'm not familiar with it at all. So I can't make any comments. But, I think I've told you before in these webinars, sometimes I learn things from you and I get new ideas from you. So I'll take a look at that. Okay. Sorry about that. Actually, let me write that one down. That's a brand new one for me to even hear about. Okay. All right. Thanks, Patsy. Hello, Paul. Are Lyme patients having more problems with the COVID vaccines? My experience is no, they are not. In fact, I'm not alone in that. So first of all, I do advocate, as many of you know, that most of my patients get the COVID vaccine. There are a number that I might not, based upon their particular situations about what has happened with them and their illness, but probably 99, 98% of my patients, I am saying that they should get the COVID vaccine. And the reason I say that is COVID kills you, okay? And COVID causes bad health consequences. And the vaccine is the most effective way we have of preventing any of that from happening, all right? In addition, I have not seen bad outcomes that are sustained in any of my patients. I have had one person that had developed severe pain afterwards, and it did take her about a month and a half to get over that. I had a second patient who developed quite severe neuropathy in her feet, but that has gone away after about 6 weeks, okay? So I just want to make you aware that yes, there is an occasional person, that will have a more prolonged recovery from the vaccine, but the majority of people are not having trouble, all right? Now, if we look at studies, there's been a study done looking at what about people with Lyme and the COVID vaccine? How does that compare to the rest of the world, okay? That study was done by LymeDisease.org and their project called My Lyme Data. And in the My Lyme Data project, so what My Lyme Data is, I think they have they may be around 13 or 14,000 people enrolled in their database, okay? And these are people with Lyme. My Lyme project will periodically query these people with questions and get responses back that they then report, all right? And their project that was published on their website in May was based on what is the experience of people getting the COVID vaccine. And what they found is that people with Lyme have the same type of experiences as people without Lyme. Same recovery periods, same degree of symptoms with the vaccine, same general outcomes, okay? So I do think it is a safe vaccine. I know that there are rare people that do run into trouble even without Lyme, but again, you have to compare that against the risk of what COVID will do to you if you get it, okay? So it's all about risk and balance, okay? If you want to see more information about this, what I just said, and also look at this study I told you from My Lyme Data, let me show you the article where I've written about this. All right, so again, take a look at my latest section here. And this is my article on the COVID vaccine, okay? All right. All right, good luck to you, Paul. So Paul says, do I still recommend the COVID vaccines? The answer is yes, I still do. Hello, Laura. Hi, Dr. Ross. What would you do if the person with chronic Lyme disease, Bartonella, Babesia had delusions? Thanks very much, Beatrice. So both the Lyme infection, Borrelia, Lyme infection, and Bartonella can give psychiatric effects. When I have somebody that has more extreme psychiatric effects like delusions or hallucinations, I am often thinking Bartonella is definitely part of that, okay? Now, I'll try to see if I can get laboratory proof of that, but even if I don't get laboratory proof of it, I assume Bartonella probably is there. It's a good probability of it, okay? Bartonella is known to give severe neuropsych issues, all right? So what would I do? Well, I'd definitely want to choose an antibiotic regimen that would cover for both Lyme and Bartonella, all right? So I'm going to give you generic on that, but yeah, you may want to take a look at my articles that I have written on how do you treat Bartonella and how do you treat Lyme, all right? And I would, a person that would present in my office for that, I would be trying to cover for both. A regimen that could treat for both would be to do something like a clarithromycin rifampin combination. Those two antibiotics cover you really well for Bartonella, and they also cover you really well for Lyme as well too. Okay? All right. Good luck, Laura. All right, so Laura, let me just do a quick screen share here. All right, so in terms of treating infections, if you're wondering how do I approach them, take a look at this article called Infection Treatment Plans. And take a look at, for Lyme disease antibiotics, take a look at this article. And for Bartonella, take a look at this article, okay? I will let you know that I'm going to be doing in the next month a significant update of the Lyme disease antibiotic guide to include more up-to-date information about persisters and how I'm going about handling that now. So that's going to be updated. And coupled with that, I'll be probably doing some updates in my Ross Lyme support protocol to cover what to do for persisters as part of that treatment as well too. In terms of what do I do for persisters in general, take a look at this article here called How to Treat Persister Lyme and Bartonella. Okay, all right. But I'll be incorporating some of this into my Lyme disease antibiotic guide. Some of this already is incorporated into my Kills Bartonella a brief guide. Okay, all right. All right. Hello, Joyce. Hold on here a minute, everyone. Hi, Dr. Ross. Let's see. Tick bite with bullseye in 2001. Diagnosed with Lyme and took doxy for 1 month. Told I was good to go, but I wasn't. Many strange things from sinus issues to vertigo to numbness in hands, feet, and face, etc. over many years. In 2016, I finally found a Lyme literate medical doctor in Connecticut who didn't call me crazy. I started with minocycline and artemisinin, then on to Cryptolepis, serrapeptase, and Beluque. Moved to Arizona in 2017, and I have yet to find any doctor who really knows anything. I have been listening to your webinars and have been on Cat's Claw, October, Sida, and Hutania over 2 years now. Every time I try to come off, I get symptoms about 2 months later. I've developed so many muscle issues, and I'm not sure if it is tied into the long-term use. Tests have shown nothing. I'd like to start tapering off to avoid the crash. What order do you suggest, and over how long? I also adhere to a healthy lifestyle, but struggle with mild yeast symptoms and treat that as well. Thank you for sharing your knowledge. Joyce, let me just make, I don't know if I'm going to give you a solid answer here, but let me make a comment. If you are getting, from what I've understood here is that you've gotten a lot better, if I'm understanding this correctly, by treating for Lyme and Bartonella with Cat's Claw, Toba bark, Sida, Akuta, and Hutania, okay? And that generally you do okay until you try to stop them, and then you get worse, all right? So that raises two questions with me. Number one, it is possible that these herbs are doing a good job keeping your germs under control, but they're not wiping them out. And one reason they may not be wiping them out is this current protocol that you have is not strong on the persister side, okay? So one thing you might consider doing, or I would have a patient of mine consider doing a situation like this, is before you try to stop the next time, you might want to add in persister coverage for at least 4 months or so before you start to remove these. At this point, I would say one of the things you could do for persisters would be the liposomal cinnamon, clove, oregano oil essentials that I was talking about earlier. That would be 1 capsule twice a day. That is good for both Lyme and Bartonella persisters and even growing forms, okay? Another option, instead of doing that, would be to add Cryptolepis in, again, both for Lyme and Bartonella persisters, and that would be at 5 milliliters 3 times a day. And you might, again, try doing that all for about 4 months. Just see if you can make a difference for persisters, okay? So that's one thought I have, all right? The other thought I have is you got to be careful with yeast. So even if you've got your Bartonella and your Lyme under control and you've got yeast sitting there, yeast in your intestines will trigger the immune system to make too many cytokines, right? And Lyme disease, as many of you know, the reason you have symptoms of Lyme are because your immune system makes too many cytokines. So cytokines are chemicals made by your white blood cells when they see a germ or a mold toxin, and their job is to turn the immune system on to deal with those problems. If the immune system isn't doing a good job of getting rid of those problems, the immune system makes too many cytokines. And too many cytokines give you headaches, make it so you can't think, give you fatigue, interfere with your adrenals and your thyroid function, make you hurt all over, disturb your sleep. You see where this is all going, okay? So Lyme disease symptoms are really too many cytokine symptoms. And if you're in a situation where you've got a lot of yeast, you may be having a hard time coming off of things too, because you've got yeast triggering excess cytokines as well too, all right? I don't know, I'm not answering your question directly because I'm not convinced that the problem is a too fast taper. I think the problem is you haven't probably gotten rid of your persisters here, to be quite honest with you. Those are my thoughts. I wish you had a physician down there you could share this with, to talk to kind of explore it a little bit more, because I don't get to ask you enough questions here to be sure about my opinion, but that's a possibility, okay? All right. Good luck to you, Joyce. Hello, Joe. See, I tested positive for Lyme via IGeneX 4 years ago. I've been trying herbals, which helped a lot at times, but still have fatigue and exercise intolerance. Now I'm ready to begin antibiotics. My doctor wants to start with 100 milligram 2 times a day for 1 month. Your thoughts? Also, what are your thoughts on... Oh, I see. So there must be a study out that I missed about hygromycin A. You guys are on top of things a little bit more than me at times. I don't know. I have to look at you're my second question tonight about hygromycin A, so I'm going to have to look into that and see. Okay, so I don't know, but I probably by the next time we meet, I will have some answers for you on that. I assume if your doctor is wanting to start you on an antibiotic that's 100 milligrams twice a day, it's either doxycycline or minocycline. That's the antibiotics that we would use at that dose. And I would say that's a good starting point. I don't have any trouble with starting somebody on that. You'll probably have to talk with them to see what their rationale is for that, okay? The one thing, though, you might want to consider, though, is when somebody has fatigue and exercise intolerance, sometimes, often, a majority of the time, I should say, that indicates that you've got a degree of mitochondria dysfunction. So mitochondria are the energy factories in every one of our cells. And by some estimates, we have 300 to 400 mitochondria per cell. Inside mitochondria is where sugar and fat are burned through a bunch of chemical reactions to produce cell fuel, which is called ATP, okay? When you have chronic infection or you have mold toxicity illness, the immune system, in trying to deal with those problems, releases a bunch of oxidizing agents as a means of poisoning the germs or poisoning the toxins. Those oxidizing agents happen to poison the covering of your mitochondria too, and they can injure the mitochondria. And that covering the mitochondria is a double layer of fat or a bilipid membrane. The type of fats that make up the mitochondria are called phospholipids, okay? So phospholipids like phosphatidylcholine, phosphatidylserine, those are phospholipids. So if that covering gets injured, there's a couple things that happen. Number one, the immune system or the mitochondria is unable to absorb sugar and fat to the inside so that they can be used as a fuel to create ATP, right? Number two, those chemical reactions that burn sugar and fat into cell fuel require electrons to be transferred to them. And what's supposed to donate those electrons is the healthy covering. So if it's damaged, you don't have good electron transfer. So you get sluggish energy generation. And you don't have enough fuel reserve so that if you exercise, you poop out or take days to recover afterwards, okay? So in situations like you just described, I'll want to do some mitochondria repair. And there's two essential components, and I'll tell you about some other things you might consider too. Number one, mitochondria repair requires fixing the phospholipid fat membranes on the mitochondria. The product I'd like to use for that is a product made by Research Nutritionals called ATP 360. And you would do 3 pills 1 time a day. It's made up of the fats that make up the mitochondria. It also has a number of micronutrients in it that help the mitochondria work well too. Okay, so that fixes it from the outside. I would also want to work on fixing it from the inside. And what does that is the antioxidant glutathione. So I like using the product by Research Nutritionals called Trifortify. It's a liposomal glutathione. I do 5 milliliters 1 time a day. Okay, now, if you are a vegetarian, you may also want to consider adding something called carnitine, also known as acetyl L-carnitine, or that kind of carnitine, acetyl L-carnitine. Thorne makes a product for that called Carnityl, C-A-R-N-I-T-Y-L, Carnityl, okay? So if you're vegetarian, you're not getting red meat, and red meat is where you get your carnitine from. Carnitine is used as a transport vehicle to carry fat to the inside of the mitochondria, okay? So if you're not getting enough supply of it, you're not going to have the transport mechanisms to bring fat to the inside of the mitochondria. So I usually will start people in that situation on 500 milligrams twice a day. And then after a month, I'll decrease it to 1 time a day, okay? All right. So let me just do a quick screen share with you here. I want to show you a couple things, or a few things. Okay, so take a look at my online Lyme guide here and look in the energy and fatigue section here. And here's my article about how to fix mitochondria, okay? And I walk you through the steps I was just telling you about, okay? Now, if you want to get the products I was just telling you about, I would just want to show you what they are and where you can get them, okay? So you can through this site, you can either reach it by clicking on my store link up here, or you can click this shop now. And basically, if it works, there it is. That'll bring you to my supplement store. This is Marty Ross MD supplements. I carry products so that my patients have high quality products, okay? But anyone can buy here. So you want to, part of the problem with supplements is there's a lot of garbage out there. So I've tried to handpick the best products that I know have been working with my patients, but also give people the best chance of recovery, okay? So if you're wondering what those are, take a look here, all right? But in terms of supplements that I like to use for problems with energy, take a look at my energy aisle here, okay? And in terms of that ATP 360, this is the product right here. Here's the Trifortify products that I was telling you about, okay? Now I want to give you a name alert. Research Nutritionals has this product called ATP 360. They also have another one called ATP Fuel. This was the old version. The new and improved version is ATP 360. This is, I'm finding it to be a more effective product, okay? All right, so don't be confused by that, okay? Now, one other thing. If you cannot take coenzyme Q10, because ATP 360 has some coenzyme Q10 in it, people that should not be on CoQ10 are people that are using atovaquone, malarone, or mepron to treat their babesia. CoQ10 will interfere with their action. If that's you, then instead, you want to use a product called NT Factor. That's this one here. NT Factor will do phospholipid repair too, but does not contain any of the coenzyme Q10, okay? This product then you would do is 2 pills 3 times a day, okay? All right. All right, now in terms of mitochondria repair, Joe, you've got to give it at least 2 months to see if it's going to help. If it is giving you some improvements, then do it for an additional 4 months, okay? All right, good luck to you. Hello, Paula. Let's see. Diagnosis, no mast cell. Why do I react severely to smells, chemicals, supplements, food, etc.? Reactions such as breathing, severe anxiety, pain in stomach, all over body pain, brain hurts. Paul, I don't know. Not everyone that has chemical or environmental sensitivities has mast cell activation as the cause of it, okay? I'm going to blank right now, but there was for people that have multiple environmental chemical sensitivities, there was a publication or research project that came up about 1.5 or 2 years ago that I always have to look up when I will look at it. And that some of those people were actually having benefit by being put on an anti-seizure medicine for chemical sensitivity that has made a big difference. So it seems to be some kind of a neurologic hypersensitivity. Let me see if I can find the name of that real quick. Hold on just a minute. Actually, let me go back here. I'll let you see what I'm doing here just a minute. Okay, let's see. Anti-seizure medicine for chemical sensitivity. Yep, there it is. So levetiracetam. That's quite a name for a medication, but it's an anti-seizure medicine. And you might want to look at this article here. So it's levetiracetam improves symptoms of multiple chemical sensitivity. And I think where I learned about this is from Dr. Horowitz has been having some success in his practice using this. I've tried it once with a patient, but they had side effects and we had to stop. I haven't tried it on anyone else, but that might be something to look at with your providers as well too. Okay, all right. All right, Paula, good luck to you. All right, everyone, that's it. It's been a good 1.5 with you here tonight. I enjoyed being back visiting with you again. As you just heard, I am off again next week. I know I've been off a lot, but last week was vacation. Next week is work. Next week is going to iLabs to learn more, to help you more. So hopefully I come back with some good ideas and I get a better understanding, especially on the peptides too. And yeah, so it's always a good meeting. I enjoy rubbing shoulders with everyone in the Lyme world out there as well too. This year will be a little bit different. It's a COVID meeting, and we'll see who shows up. But I definitely plan on going, and we'll see what I can bring back that will help things here. All right. So tomorrow morning, you will be getting an email from me announcing that the recording is ready to be viewed, and I will provide a summary with that as well too. In that email, there will be a link that you can use to sign up for the next webinar, which is actually 2 weeks from now. Okay. All right. And yeah, so take a look at that. When you get the email, everyone, share it. Share it with people that you think might get benefit. Share it with people that you think that might want to participate in the next webinar. All right. Help me reach people. I'm trying to help as many people as I possibly can, but I need you to help me do that as well too. And I appreciate it when you do that. All right. Good night, everyone.